Good afternoon, everyone. So I welcome you all for this where we are going to talk about dialysis. As you know, dialysis has been and will explore ways of renewable medicine therapy. In other countries, many patients being put on dialysis as soon as they are diagnosed as end-stage kidney disease. But in our country, we are used to going for peritoneal dialysis whenever we don't have a vascular access. So to increase the number of patients on peritoneal dialysis and to develop our expertise in peritoneal dialysis, we have undertaken today this session on peritoneal dialysis. Today we are going to have 4 eminent personalities who are going to talk on peritoneal dialysis, namely Professor Fachu Ambiola Ogungadali, Dr. David Ip-Minwan, Dr. Rizwan Hamad, and Dr. Jyoti Baharnani. So, as first speaker, I am going to welcome Professor Fachu Ambiola Ogungadali. Professor Fachu, are you here?
Hello?
Yes. So welcome to Ambiola Ogungadali.
Can you hear me?
So Professor Fachu has an MBBS from Laos. He's FMCP, ISN Fellow, FWACP, FRCP, and he had his basic medical degree from the College of Medicine, University of Laos, and postgraduate training at the Obafemi Owoluwu University Teaching Hospital Complex, ILFE. Professor Gandari was promoted to the grade of Professor in Medicine and Nephrology at the Obafemi Owoluwu University in October 2011. He is also a honorary consultant physician nephrologist at the Obafemi Owoluwu University Teaching Hospital Complex, LFE, Nigeria. So, Professor Fachu, I leave you the floor.
Hello?
Hello, sir.
Can you hear me?
Yes.
Thank you very much, David. Distinguished colleagues, good afternoon. It is indeed my pleasure to participate in this webinar aimed at fostering the International Society of Nephrology Sister Renal Center collaboration between Birmingham Heartlands Hospital, UK, and the SSRN Hospital in Mauritius, with one of the major objectives being the promotion of peritoneal dialysis, its usefulness, applicability, and effectiveness in Mauritius. I need not start talking about Mauritius to us because we know more about Mauritius than myself. But suffice it to say that Mauritius is a beautiful country, though small in size, which is multilingual, several different cultures, and multi-ethnic state, with a population of almost about 1.4 million. We all recognize in Africa that Mauritius renal care is advanced, despite the small size of the country. Mauritius has several government-owned renal care centers and several private ones. And it is instructive to note that hemodialysis therapy and other forms of kidney replacement therapy is totally free, unlike what we see in several other African countries. Kidney transplantation is available in the country. And in sub-Saharan Africa, apart from South Africa, Mauritius is the only other country that has launched a disease donor program. This was done only a few weeks ago. So in terms of rating, Mauritius renal care is really advanced. Peritoneal dialysis, unfortunately, appears to be the least developed in Mauritius. And that is why this is one of the cardinal objectives of the partnership between Birmingham and SSRN Hospital in Mauritius under this SRC linkage. And like we all know, peritoneal dialysis has peculiar advantages, particularly in early renal failure, in preserving residual renal function, and of course, in guaranteeing the freedom of the patients among several others. So to be worthwhile operating a PD first policy in a country that has free access to renal replacement therapy like Mauritius. And to talk about the International Society of Nephrology Sister Renal Center program, it's a program aimed at developing centers in the emerging economies that will be more mentored, as it were, by centers in developing countries, which is the support Birmingham will be providing for Mauritius in this relationship. The SRC program has 3 levels of support, providing the framework and funding to foster up to 6 years of collaboration if adequate progress is made. So the program is monitored, and on successful completion of a particular level, an institution can progress to the next level. If, however, the institution is not successful at that level, the institution will be given an opportunity to remain itself for another term of 1 or 2 years, after which, if there's still no progress, the institution is made to exit from the program. It is my humble prayer that Mauritius will graduate. If the institution progresses from level C to level B after 2 years, and then with additional funding at the level B, the institution could progress to level A. And then after 2 years of also successful completion of the program, the institution could graduate. The long-term goal for the SRC is for the emerging center to become self-sufficient and to be able to provide better treatment and outcomes for patients with kidney disease in their care. After 6 years of improvement on the program, graduated centers are encouraged to equally now support the 3rd center within their region, and therefore sustain the impact of their training and help other centers to equally develop and also graduate. The SSRN Hospital in Mauritius is one of the major referral centers in the country, and it's the coordinating center for other 5 regional hospitals, and will be coordinating the development of all renal replacement therapies, including peritoneal dialysis. It is my hope that this relationship will blossom get distinguished colleagues, ladies and gentlemen. It's therefore my pleasure to launch the commencement of the ISN Sister Renal Center Partnership between Birmingham Heartlands UK the SSRS to further actualize the vision of the ISM. We hope that this will result in the establishment of peritoneal dialysis as a significant option of kidney replacement therapy for the people of Mauritius. Thank you very much, and God bless you. Congratulations, Mauritius and Renal Society of Mauritius. Thank you.
Thank you, Professor, for this nice talk. I would like now to welcome our doctor, Dr. David Minwan. He's a consultant in charge in nephrology and is working at the SSR North Hospital. He studied at the University of Edinburgh Medical School and trained in the hospitals of Edinburgh and Sheffield before getting his MRCP UK. He trained as a nephrologist and physician in the West Midlands before coming back to Mauritius in 2012 to join the Ministry of Health and Wellness. Dr. David Minwan has just completed his term as president of our Renal Association. So Dr. David, who is always busy, I welcome you on this week.
Thank you very much, Mahesh. And very big thanks to Prof. Patu Arobundade from Nigeria, which is a considerably bigger country than Mauritius, and I think even with more diversity of people and languages. And I want to underline that Prof. Arobundade, he's the co-chair of the ISN Africa Board, and I understand that he will become the chair soon. Now, just before starting, I'd like to remind people here, if you haven't filled the survey, please direct your phone and get the QR code to fill the PD survey, preferably before we really get started today. If you don't get time to get the QR code, you just go on the website, which is renal.mu, and the survey is on top of the page. For those who have filled it, thank you very much. We already have 50 respondents. So this is the program. So we just had the launch from Prof. Arobundade, and we speak on peritoneal dialysis in Mauritius. Then Dr. Rizwan Hima will speak why choose PD, and then Dr. Zaharani will talk about patient selection for PD. So I'm going to speak a little bit about the PD situation in Mauritius, or not. Because I actually don't have a lot of slides on PD in Mauritius in this talk. Just to remind you that in Mauritius, the population is now starting to shrink, and it's happened in the last 2 years, some 10 years earlier than expected. And instead of having an expanding population as we did after the 1960s boom, now we have an aging population, which is typical of the more advanced and westernized countries. And it does have a lot of implication on the prevalence of kidney disease and also on the how we give care to kidney patients. So for those who are not from Mauritius, this is a map of Mauritius. It's 40 by 60 kilometers, and the healthcare is divided into 5 regions, and each has a regional hospital and possibly 1 or 2 smaller hospitals. So we have 5 main dialysis centers, but there are also some 3 secondary dialysis centers in the public sector. Mauritius is a country of diabetes. The latest survey shows 20% of that prevalence of diabetes. It is somewhat lower than the previous two surveys, so possibly it is decreasing, but we're still in the top 10 worldwide in terms of prevalence of diabetes. And of course, we know diabetes is one of the main causes of kidney disease in the world, but also especially in Mauritius. This chart shows that in 2021, we were number 8, and on these projections, we were meant to go to 4th in 2045. As of the obesity pandemic, we're not doing too bad, and you can see Mauritius here in the pale blue. So we don't have seemingly a high prevalence of obesity, but we need to remember that obesity needs to be considered on ethnic cutoff points, and because our population is mainly Asian, so if you consider that we actually have a fairly high level of obesity, but not as high as the Middle East or the South Pacific. And for hypertension, we also a middling country. What about kidney disease? So these are data from the non-communicable disease survey again, which is done every 5 to 6 years. And you can see that in 2009, 12.4% of the patients had albuminuria, and EGFR less than 60, 7.6. So we could see that maybe the prevalence of CKD could be estimated at 15 to 17%. There will be some intersection between these two groups. And in the next two surveys, 2015 and 2021 especially, the numbers have gone down. In 2021, it is suggesting that the prevalence of kidney disease in Mauritius is about 8%, which is marvelous, given the world average for CKD is 10 to 12%. And more health statistics show that only 50 people die of kidney disease in Mauritius in 2018. So do we see that in practice? As far as the Lancet is concerned, the Global Burden of Disease study that came in 2020, and you can see that Mauritius at the bottom is a particularly red hotspot. And according to that, there are 280,000 people out of 1.65 million people with kidney disease. That does seem to be very, very high. And it corresponds to a prevalence of about 13.7%. And if we look at the classification, globally, we are second after Fiji in terms of prevalence, but also in terms of deaths. So what about our own experience in our dialysis unit? What are we seeing? So we did publish a little paper on that, and we showed a nice map on Mauritius. And Mauritius actually is not just an island, but an archipelago, and we do have dialysis unit as well on the island of Rodrigue, which is 550 kilometers away. So at that point in 2021, we found that we had a 1,579 dialysis patients, both in public and private sector, and including Rodrigues as well, and 175 transplant patients. So only 10% of the patients were transplanted. The rest were hemodialysis, except 1 or 2 for PD, meaning that PD has a prevalence of 0.01%, very low. The population of Mauritius now, as I mentioned, has stopped growing, but the number of patients on dialysis, whether you measure it as the raw figure or per million population, keeps rising. But what is also clear that we do not have enough nephrologists in Mauritius. And if we look at the number of nephrologists, as you know, the right-hand side, we've got 7.5 per million population compared to South Africa, which is 2.5, and which puts us in the middle of the right-hand bar chart. But if you look at the number of patients we have on the left hand, we see that we only have 5.7 nephrologists per 1,000 end-stage disease patients. So we're definitely lower down in the chart. And in that case, South Africa does better because we do not dialyze many of their patients. And this graph is a month-to-month prevalence of hemodialysis patient in Mauritius, and you can see it reached a peak in at the end of 2020. After that, we had the COVID pandemic, and that's part of the explanation why it has decreased. And if you look at the incidence of treated end-stage kidney disease, so new patients suffering dialysis in Mauritius, we have about 700, and we still have a 10% actually AKI. So even if we take it out, we estimate about 450 to 520 per million, which puts us almost at the same level as Taiwan, which is the country with the highest incidence of kidney failure. And for prevalence, we are about 12. So these figures really suggest that we are really near the top of the global classification prevalence of CKD. And the main reason is diabetes, and we think we have about 60% of the patients have kidney failure due to diabetes. So again, we are number one. And on the left-hand side, we have the population pyramid in 2021 for Mauritius. On the right-hand side for the dialysis patient, and you can see clearly there are a lot more men, twice as more men than women, and they are skewed towards the LD. Most patients are above 50. We also have done transplantation, lab-related on and off in Mauritius, and the most transplants were done between 92 and 2017, and then it stopped when we sent patients abroad, and then it's just restarted. So what about PD? Actually, I don't have a slide on PD because there's nothing much to say. Actually, the first form of modality of for treating kidney failure, kidney replacement therapy, was PD in the early 70s. Dr. Ip, the other Dr. Ip, told me he got a PD catheter and treated the patient with acute kidney injury. And after that, there was sporadic use of acute PD until we had the first transplant in 1980, and then dialysis in 1992. And once hemodialysis started, PD petered out. So typically, we only have 1 or 2 patients on PD Mauritius. They are patients who have used up all the possible access for hemodialysis, and we haven't had any patient who choose PD and stop from the start. And all these patients last weeks or just a few months because of peritonitis. The longest lasting patient was a patient of mine last year, 9 months. So there are a lot of questions why we are not successful in PD in Mauritius. Now, just a few words about this program, as Prof. David mentioned. So it is a worldwide scheme. We can see that UK participated in a lot of this partnership. And this program is to provide a framework and funding to foster up to 6 years. So this has been mentioned already. So this is an example of what can be done. This is in Bangladesh, where they are giving hands-on training and scientific meeting on PD. So in the first 2 years, we have an annual budget of actually $2,000. They increase it because Mauritius is very far from the UK, and then 10,000 per year and 12,000 USD. And just a list of things you can spend it on and not. And so last year, I applied this for this. I think I did it very quickly in a matter of days, and so the focus of our partnership would be on adult nephrology, on critical dialysis, but also on acute kidney injury, on palliative care for CKD, and interventional nephrology. And everything will be scrutinized by the ISN, so we've had to put what we would like to achieve, what are the outcome, and what are the measures we're going to do. So I won't go back in detail. So I really hope that everybody, the nephrology will work together so that we can progress to the next stage. And ultimately, it is for the good of Mauritian kidney patients. So the first year, this is the program. So today we are doing 1 and 2, and the next 2 would be peritoneal dialysis specialist nurses, and the 5th one is a surgeon. And we've got a number of projects, but I've had to present to the ISN. And eventually on the 14th of January, we got the letter from the ISN and we've been awarded the program. So I would like to thank particularly the ISN, but especially Dr. Baharani Jyoti, who's kind of pushed me into applying that. And despite being very busy, I just managed to scribble something and a lot of spelling mistakes I've just seen in this application. Anyway, we made it, but it's just the start of an exciting adventure. And we hope that we'll have a lot of success, especially for our patients. Thank you. And we're going to move directly to Rizwan Hemad, Dr. Rizwan Hemad. He's a consultant nephrologist at University Hospital, Coventry in Warwickshire. It's actually a particular post I used to occupy when I was in hospital, and it took over in 2012. So I'm very, very happy to see him today. So we're still good friends and colleagues. He's a clinical lead for peritoneal dialysis with almost 100 patients under his care, and also the lead for clinical audit and his hospital. His main interests include peritoneal dialysis and renal transplantation. He's got a particular interest in practical procedures and has inserted over 500 PD catheters percutaneously. Also, let's see, he's a keen painter, especially into watercolors. Welcome, Rizwan.
Thank you, Davey, for that introduction. I hope you can all hear me.
Yes, we can hear you.
Excellent, excellent. So I apologize in advance. I might sound a bit nasal. I have a bit of a cold, and it's not COVID, but it's a bit of an unpleasant cold that I have. So if I'm blowing my nose or something, I apologize in advance. I'm going to try and share my screen now, and I hope you can all see that.
Yes.
Excellent. So the topic that Jyoti suggested I speak on is why choose peritoneal dialysis. Now, we heard a professor earlier speak about, sorry, let me just, yeah, I can't see my screen. Okay, so we heard a professor from Nigeria. I'm afraid I didn't catch his name. My apologies. Speak about PD first. The PD first concept implies that when feasible, PD should be offered as the first dialysis modality. This concept of PD first and HD second must not be seen as a competition between therapies, but rather that they are complementary, keeping in mind the long-term goals of the patient. So this is a cartoon from 2015 showing the prevalence of peritoneal dialysis worldwide. And as you can see, very few countries, in fact, are in green there with PD prevalence rates of over 30%. In fact, the vast majority are either white with no PD utilization or gray, less than 10% utilization worldwide. And this other cartoon is a bit more telling. You can see that apart from countries like Hong Kong and Mexico, the rest of the countries in the world actually use very little of peritoneal dialysis, going right down to Egypt, where no PD is used or almost no PD is used. So in 2018, the prevalence of peritoneal dialysis in the world was 38.1 per million population. But this varied more than 5,000-fold. And you can see that in Hong Kong, for instance, whilst it was 531 per million population, in Egypt, it is only 0.1 per million population. And only 11% of dialysis patients were on PD, meaning that close to 90% were on hemodialysis. And of these 11%, more than half of them lived in just 4 countries, China, USA, Mexico, and Thailand. So PD was not available in 30 countries, And this came as a shocking statistic to me. 20 of these countries are actually in Africa. There is no PD available there at all. And PD use was 60-fold lower in low-income countries compared to high-income countries. So why is this the case? And I'm hoping over the next few minutes to try and share reasons why PD may be poorly utilized, and perhaps convince you why we should try and use PD a bit more than we are just now. So let us look at the costs of peritoneal dialysis. This is a paper from Canada that looks at the cost utility of dialysis, hemodialysis, peritoneal dialysis, and no dialysis at all. And what you can see over here, that for every quality adjusted life year, hemodialysis cost $105,000 almost, compared to $83,000, $84,000 for peritoneal dialysis. So PD is a lot cheaper than hemodialysis. And this is a study from Babulal in 2008 from the United Kingdom. You can see that APD costs £21,000, CAPD 15,000 pounds, and hospital hemodialysis was more than double that at £35,000. Now, this is an old study, but a more recent study, actually, fairly recent one, shows that the numbers haven't changed very much. CAPD costs something like £16,000, APD something like £23,000. But look at this hospital hemodialysis. We are close to £33,000. So really double the cost of CAPD. This is a study from the United States that shows that, it was a retrospective study looking at Medicare beneficiaries who started dialysis between 2008 and 2015. What they did was compared in-center hemodialysis to peritoneal dialysis in patients who were over 67 years. And the average expenditures in 2017 was 108,656 for hemodialysis, compared to a little over 91,000 for peritoneal dialysis. So again, a significant difference between using hemodialysis when compared to peritoneal dialysis. So what if we move away from Western countries? And this is a study from Thailand. This is a study from 2007, and it's actually an extremely important study, because what it showed was that the cost of hemodialysis was $24,000, $24,500 compared to $20,400 for PD. And this actually was a study that paved the way for the PD First policy in Thailand in 2008. As a consequence, the number of PD patients in Thailand rose significantly. In India, this is a study from Professor Jha of the ISN together with Dharna Gupta, and their conclusion from this study was that as initial treatment, PD was a cost-saving option for management of renal failure when compared to hemodialysis. So what are the issues then? Well, unfortunately, in most low and middle income countries, the cost of fluid is often borne by the patients themselves. They're expected to purchase these fluids. And that, of course, can be a bit of a problem. So in many African and South Asian countries, the cost of PD is actually much higher than hemodialysis. And this is an old study now, but it looks at the cost of PD fluid bags in Sri Lanka. It cost $8 a bag. And at the time, the gross national income was $820, making PD impossible to use, actually. People just could not afford it if they were going to pay for the bags themselves. And this study showed that in India, for PD to be cost effective, the price for consumables would have to be reduced by 2/3. Otherwise, it would make PD impossible to use. So what are the potential solutions? And I would encourage us to think about this, because this has implications for establishing peritoneal dialysis in low and middle income countries. Well, the first thing we need to do perhaps is increase public funding for renal replacement therapy. And then to reduce the cost of commercially produced dialysis fluids. Now, this may require some negotiation with companies that produce dialysis fluids, but certainly if we don't take the step to try and get it down, it will not go down. We also need to look at the ability to produce dialysis fluids locally. And then perhaps better procurement methods, bulk buying, getting governments to waive custom duties. Well, in fact, one of the things that is thought to be an impediment to PD establishing itself in countries how government looks at peritoneal dialysis. And then we need a policy initiative to support PD first policy, and perhaps using incremental dialysis, where instead of every patient having 2 liter bags 4 times a day, perhaps those people who first start peritoneal dialysis could get away with doing 3 bags or 2 bags, or perhaps not doing PD every day and gradually increasing it as the need arises. This could lower the costs to start with. So what about the quality of life on peritoneal dialysis? Well, this is a study from South Korea, which shows that even after adjusting for clinical and socioeconomical variables, there's often the case to say that PD patients are different from HD patients. You can't compare. It's like comparing apples and pears. But this study tried to adjust for clinical and socioeconomical variables, and they showed that patients on PD had a better health-related quality of life compared to hemodialysis patients for at least 2 years. This is a systemic review from Thailand, I think, that looked at 21 studies with 29,000 patients, and again concluded that PD patients had a better quality of life when compared to hemodialysis patients. So there are multiple. I mean, I could go on and on and on, and we'd be here for a couple of hours talking just about quality of life. A number of studies have shown that patients on PD have higher employment rates, and that's something that could be negotiated and explained to government officials. They have higher employment rates, they have more ability to travel, they have a better functional level, they have more recreation levels compared to patients on hemodialysis. What about residual renal function? Now, I think we spoke about, it was mentioned about residual renal function as well earlier. So does it matter whether you have residual renal function or not? This is a study on hemodialysis patients, but it looked at, it's a prospective observational study over 2 years to see whether residual renal function actually made a difference or not. And after adjustment for dialysis duration, age, smoking, diabetes, cardiovascular disease, serum albumin levels, and the urea reduction ratio, what was definite was that residual renal function was protective against death with an OR ratio of 0.44. So very significant. If your patients continue to have a significant amount of residual renal function, they are less likely to die. So what are the predictors for residual renal function? This study from the US looked at various predictors and found that female gender, non-white race, diabetes, congestive cardiac failure, and time on dialysis were predictors for losing your residual renal function. But PD was actually associated with preserved residual renal function, with up to a 65% lower risk of losing your residual renal function when compared to hemodialysis. This is extremely significant, I think. What are the other benefits of residual renal function apart from mortality? Because people argue that, well, it's not just death that counts, it's also other things. Well, this is a study from Canada, I believe, that looked at blood pressure, and they found patients on PD had a better blood pressure control. This is a study from Denmark, or some European studies that showed patients had better fluid status, less chances of getting fluid overloaded compared to hemodialysis patients. Study by Angela Wang from Hong Kong, which showed that patients who are on peritoneal dialysis had preserved left ventricular function, and their hemoglobin levels were also better. And this is another study that showed that the clearance of solutes could also be better on peritoneal dialysis. So what about hospitalizations? Patients on PD, are they more likely to be hospitalized or not? Now, this is slightly controversial because what various studies have been done to look at this, and some studies have shown that patients on PD are more likely to be hospitalized, less likely to be hospitalized, or just the same as hemodialysis patients. With hemodialysis patients, of course, they tend to get admitted because of interventions like angioplasties for their fistulae, or because they tend to get systemic infections. With peritoneal dialysis, patients have fewer interventions because of a lower risk of primary access failure. And the main reason for hospitalization in PD is therefore infection. And this therefore means that if we can get our infection rates to go down, which is a big thing, obviously, worldwide, the ISPD has recently published their guidelines on infection control for peritonitis, PD-related peritonitis. If we can get those down, then the hospitalization rates of PD should also go down. What about transplant outcomes? So this is an excellent meta-analysis, I think, from China, which showed that patients who had PD first before their transplant, when compared to hemodialysis patients who went to get transplant, had a lower risk of delayed graft function, had a higher rate of patient survival over a 5-year period. And there was a 5-year graft survival benefit as well. Another meta-analysis from the United States showed that pre-transplant PD was associated with better post-transplant patient survival, quite significantly, and also a decreased risk for delayed graft function. In this meta-analysis, however, there was no difference in graft survival between pre-transplant HD or pre-transplant PD. What about patient survival on peritoneal dialysis? If you put patients on PD, are they likely to survive? Do they die sooner? Well, in this USRDS report showed that the 1-year probability of survival from peritoneal dialysis rose from 85% or almost in 2003 to 90% in 2013. So better survival rate. In Canada, they had similar results, and I'm going to show you this graph, which by Jeff Pearl from 2012, and you can see over here that the death rate has steadily dropped on patients on peritoneal dialysis. Okay, if France showed similar results as well. The risk of death from peritoneal dialysis has been dropping. What about survival for PD compared to HD patient survival? Well, this is a study that showed that patients for the first 2 years had a better survival on PD compared to hemodialysis. This is a US study. And the initial advantage of peritoneal dialysis relative to hemodialysis was again shown by this European study. There is another report here which showed in Korea there was better survival in peritoneal dialysis compared to hemodialysis. And I would urge you to read this article by Mark Marshall, which shows the benefit of early survival on PD versus HD, why it is still very important. I quite like this study from Colombia, which shows that despite PD patients being poorer when compared to hemodialysis patients, more likely to have diabetes, have higher comorbidity scores, the adjusted mortality risk in PD was the same as hemodialysis. What about using peritoneal dialysis for acute kidney injury? Well, a number of studies, and I'm not going to go through all of these, but a number of studies show that actually you can use peritoneal dialysis in the ICU setting. Some studies show that it's just as good, if not better, than using CVVH. There were studies, a lot of reports of patients using peritoneal dialysis for AKI associated with COVID, even in the ITU setting. And in fact, we used it ourselves for our patients with good results. So this is a study of AKI in Africa, which shows the outcomes of acute kidney injury in children and adults. It's a systemic review. So the mortality rate from AKI in children was 34% and 32% in adults. But if you did not have dialysis available, then it went up to 73% in children and 86% in adults. So, remarkable mortality if you cannot provide peritoneal dialysis, or if you cannot provide any form of dialysis in the setting of AKI. So my question is PD for everyone? And I think my answer is no. PD is not for everyone. And I think Jyoti is going to speak to you about how to select patients for PD, who's suitable for PD and who's not. Obviously, there are medical reasons for it. I'm a very big proponent for patient autonomy. So whilst I'm PD biased, I prefer PD. I'm not always in favor of a PD first program as a form of a policy where it is mandated every patient must have PD unless there's a very good medical reason not to have PD. I think patients should be allowed, they should have the autonomy to select, but this has to be our role, is that as clinicians, we should not be biased against PD, and we should provide good information to patients so that they can make decisions. The shared decision making between patients and doctors must involve all these things that I've just spoken to you about, the advantages of peritoneal dialysis. If we don't tell our patients this, they may make the wrong choices. And so I'm going to say that, you know, we should always ask ourselves, when we see a patient with kidney disease who has got end-stage renal failure, either acutely or a chronic, from chronic kidney disease, why not use peritoneal dialysis? I'm going to stop there and hand the mic over back to Davey. Thank you so much, Davey.
Thanks very much, Rizwan. I think we are taking questions at the end, so I invite the audience to start thinking about the questions and please ask me at the end. Of course, today it is a special day for us in Africa. We had Prof. Arabunda who launched it, and he was one of the authors in that paper presented by Rizwan just now. And obviously Mauritius is part of Africa, and Rizwan is actually African as well, because he's born in Zanzibar. And we come to Jyoti Baharani, and she also has an African connection with family coming from Kenya. Am I right? Kenya, not Uganda.
You're right. I was born in Kenya.
Yeah, you're born in Kenya. And Jyoti, I don't actually seem to, on the one hand, know Jyoti quite well from the various online meetings, but I've never managed to meet her. So Jyoti trained in rural medicine in the north of Scotland as a nephrologist and associate medical director at University Hospital, Birmingham. She holds honorary clinical lectureship with the University of Birmingham, and is a training program director for renal medicine and renal medicine in the West Midlands. She is also a regional advisor for nephrology in the West Midlands for the London Royal College of Physicians. She is clinical lead for a home therapies service at UHB, and she has various research interests, including pre-dialysis, AKI, health inequalities, and modality protocol dialysis, custom access, PD, end of care in dialysis, and of life care in dialysis, breaking renal disease. So the floor is yours, Jyoti.
Okay, thank you, Davey. I'm just going to share my slides. I hope very much that I'll be able to. Zoom has a mind of its own sometimes. Can you see my slides?
Yeah, it's coming up. Yeah.
I'll just put them in PowerPoint mode. So hopefully, for some reason they've decided to go right to the end. I'll just go to the top again and share. Is it in PowerPoint mode now?
Yes.
Okay.
Perfect.
Thank you, Davey. Like you say, we've never met. I was appointed in 2004 in Birmingham, having worked, I have been trained in Scotland after finishing my medical training in Dundee and my renal training there. And Davey and I've always missed each other by a few months. I think he had just returned to Mauritius when I'd been appointed to Birmingham. And then when he was in England, at Christmas time, we also missed each other just by a few hours. So I am hoping that one of these days this virtual relationship will become in real life. I work in Birmingham Heartlands Hospital, which is one of the teaching hospitals based in Birmingham. And as a conflict of interest, I'd say that if I had kidney failure, I would probably choose to have peritoneal dialysis, And I have to respectfully disagree with my colleague, Dr. Hamer. I think PD is for all, because unless we adopt that ethos that PD is for all, we will never be able to offer it to the patients that really want it. And I hope to convince you a little bit today about how we developed the program at Birmingham Heartlands, and what issues that you need to, or nuances that you need to think about. I think we've heard from Rizwan already that worldwide kidney failure is a big issue. It's certainly a big issue in many African countries, including Mauritius, yet the predominant modality for kidney replacement happens to be hemodialysis. Worldwide, between 5 and 15% of patients are on peritoneal dialysis. The vast majority are on hemodialysis, and the ones that are on, sorry? Oh, somebody said something. The ones that are on peritoneal dialysis tend to be concentrated within countries that have a PD first policy. So this is just really a reminder of what Rizwan said. I think I just want to start off with, the pathway to dialysis. So certainly in the United Kingdom, we ask for primary care to refer patients to us when it's clear that these patients are heading towards renal replacement therapy of some sort. So all CKD 3B and above is referred to secondary care from primary care. And we have a very lean system locally. So if anybody has a GFR of less than 25 and on the kidney failure risk equation is likely to need dialysis within the next couple of years, then we pull them into our pre-dialysis setting. We already know that a late referral will translate as a barrier to peritoneal dialysis, because unlike hemodialysis, PD actually takes a lot more thinking and a lot more work on the part of a healthcare clinician. I always say to registrars or trainee doctors when I'm teaching that hemodialysis is easy. Whether it's easy for the patient or the clinician is another matter. But there's always room at the inn as far as hemodialysis is concerned. Peritoneal dialysis, despite all its advantages, despite all its good bits, still becomes a bit of a difficult process, even in countries that have structured pathways that allow patients to have home dialysis. And I think the education process is really, really important. It has to be unbiased, and it should really involve patients and those with lived experience. Now, that's quite difficult if you don't have patients, who are on home-based therapy, but there are ways around it, because you can deploy peer educators, so people with lived experience, but not necessarily lived experience of that particular treatment. And education is more than just handing out literature. It is about shared decision making. And if I put you into a scenario where you go into a clinic situation and the doctor says, you can come to a dialysis unit, which is potentially air conditioned. We will look after you 3 times a week. We will put you on dialysis. We'll do everything for you. When you go home, and you don't have to think about the dialysis. And on the other hand, there is this other treatment where you're going to have to look after yourself, take charge of your condition, do the dialysis for yourself. What would you choose? So I think the way we give information is quite difficult. I mean, a lot of the times we talk about the nuances and intricacies of the treatment, but we don't necessarily talk about the quality of life, the fact that they might be able to travel much easily, the fact that actually they might live a little bit longer because their residual kidney function will last a bit longer, and the fact that, they may actually get a transplant much more easily. So those are the kind of soft bits that, we don't necessarily talk about. And I think for patients, it's quite daunting to have to make a decision. So what I would say, although we allow autonomous decision making, as clinicians, we do no harm. And if a patient is choosing what modality they want, that's fine. But it's very rare that patients have the same level of insight that, clinicians have. And I would ask you, if you wanted dialysis, what would you choose? Most, we know from studies done previously, including our own work in the United Kingdom, most clinicians in renal medicine would want peritoneal dialysis or home hemodialysis So why the discrepancy between what we want and what we offer our patients? I think MDT discussion is really important, and what we have done at Heartlands is we've evolved an MDT that we usually discuss patients that are borderline, and we try and individualize the mode of dialysis to the particular patient. So I think the pathway to dialysis is really important, and that's one of the things that I think, as a collaboration, we do need to look at. There are lots and lots of factors that influence the type of dialysis patients choose. From the physician point of view, if you only have experience in hemodialysis, of course, you're going to be biased towards that treatment. You are going to think of the clinical advantages, a little bit about the quality of life, but we know from the SONG data from Australia that what is important to clinicians isn't necessarily important to patients. So it's really important that we consider that these things are important to us as clinicians, but actually what's important to patients. We know a lot more about complications, so that will always figure in our brains, and we have a lot more knowledge. But for patients, things like survival, can I actually travel? Can I go and see my grandchildren on the other end of Europe or the other end of Africa? Will I be able to work? Can I have, can I manage my family and my house? Is my house going to be good enough for this treatment? Those are the kind of things that patients think about, completely different from what clinicians think about. And of course, there's economic factors. If a country is reimbursing more for hemodialysis, then it's invariable that the treatment of choice in that particular country will be hemodialysis. And if your government polices the policy and says everybody has to have PD, then that will determine what modality people go on. And of course, the resources. I mean, Rizwan spoke very eloquently about the ways to try and improve PD uptake. Actually, PD fluid is just salt and water. It isn't very difficult to make. At one point, we were thinking of perhaps manufacturing it in our pharmacy during COVID when we were running out of CRRT fluid. So it's not particularly rocket science, but I think, unless there is a need for it, pharma and big companies are not going to invest in it. And I think as clinicians, it's important that, we have to sort of push this, because pharma is probably not going to do it. And there are no national recommendations or international recommendations that hemodialysis should be the modality of choice, but it has become the modality of choice. And I would argue that most of the barriers that we quote to patients to PD are from clinicians, and they're not from patients, and most of them are not even medical. And this has prompted some countries like the US to have the Advancing Kidney Care Quality Initiative, where they've introduced general statutory measures that 85% of the patients starting kidney replacement therapy will either have a sort of a transplant or a home therapy. And what I would urge you to do is, when you go home this evening or go back into your units tomorrow, is just have a little think about, what percentage of your patients who are in your unit that are on hemodialysis could actually have had PD and could actually still have PD. There's lots of issues, there's lots of factors that can, affect PD selection, but I think they pale into insignificance when you think about the clinician and the patient, because most of the issues are raised by either the patient or the clinician, and the others just fade into insignificance because they're all workable around. So my patient selection criteria, I run the pre-dialysis service as well. We have about 600 patients at various stages between CKD 4 and 5. And I usually, unless there's a very good reason, will offer PD to most people. And the way I speak to patients and the way I counsel patients is saying, if you want it, we will work around the problems. There's no real way of knowing if PD will work or won't work unless you actually try it. And I'm going to talk to you about, there are a couple of absolute contraindications, but I don't like the word absolute. So I tend not to use it. And if I really think PD is not the right modality of choice for this patient, then I speak to them about why I think that. And in those patients, there may be a potential to get an early AVF or early fistula as well, or you could insert the fistula at the same time as you put in the PD catheter. I tend not to do that because that kind of undermines my ability and my belief, or the patient's belief in PD as being a modality. So we've really abandoned making a fistula at the same time as putting in a PD catheter. And these are the common reasons why, as clinicians, we don't offer PD to our patients. We think they're too elderly, they won't cope with it, they're frail, they're diabetic, their sugars will go up, they're too obese, they've had previous abdominal surgery, or they've got a gastric feeding tube or some sort of stoma, they have hernias, they've had a previous aortic aneurysm repair, they've got a VP shunt in place, they have liver disease, they have connective tissue disease, they have polycystic kidney disease. I've led the PD service at Heartlands since 2014, and I think that the strangest reason I was given by a colleague about why somebody couldn't have PD was because they had adopted children and it would be too traumatic for them. And my argument was that actually not seeing the mother or the father for 4 hours, 3 times a week, would actually be a lot more traumatic. So, I think sometimes we just go and look for issues where there aren't any. And Rizwan has known me for a long time, Davey too, and they know that if there's an obstacle, I will always think of a solution. So things like dementia and physical barriers, I mean, we have a assisted program in that we pay an external company to go and build the PD machine and connect the patient at night. But that can easily be done by a relative or a carer, and sometimes those carers need to be paid. Most people, I would argue, live within extended families. I suspect that is the case in Mauritius. So, there is a potential to use an assisted delivery service, even though, it's not a paid for service, if that makes sense. And of course, there's also automated peritoneal dialysis, which reduces the number of changes that the patient needs. So, so if they've got physical barriers, then overnight dialysis rather than CAPD. Swimming, I'm sure a lot of people in Mauritius love to swim, and things like using special covers, ostomy bags, and swimming in swimming pools rather than in the sea. We've never put in any pre-sternal PD catheters in my center, but in North America, where patients are probably bigger than average, there is a vast amount of experience using pre-sternal PD catheters. So instead of tunneling the catheter towards the away from the umbilicus, you would tunnel it pre-sternally. And patients with ileostomies and colostomies, again, if they really want peritoneal dialysis, then there are surgical methods to be able to give them PD. Polycystic kidney disease, these patients do sometimes struggle with the volume that you put in, but you can always adjust that. Dialysis machines nowadays are very clever. Hemodialysis machines are clever, but PD machines are probably as clever. Having pets, it's important that pets are kept away from the equipment, but having a separate room for exchanges or rehousing the pet, if the patient allows that, is a way around it. And things like hearing loss and visual loss, there are plenty of patients that we have locally that use various alarms and UV lights to be able to get them onto the dialysis. So, if there is a solution, if there is a problem, that usually it's a solution. But this is probably, not the group of patients to start your PD program with. These are the patients that, come at a later stage. And certainly when we were building up the service, I still don't have any patients with an ileostomy or a colostomy on peritoneal dialysis, but I've often said that before I retire, I will offer it to a patient and see if they want it, we can try and get them on it. And again, I think, these are groups of patients that we see very commonly. Patients who are elderly, have diabetes, are obese, have polycystic kidneys, have had previous abdominal surgery, liver disease, have had previous graft failure from a transplant, or need dialysis acutely and have heart failure. They all have solutions. And I think it is just about building up the program, developing the expertise, and then being able to offer your patients these solutions. There are some contraindications to peritoneal dialysis, and there are two main ones that are absolute contraindications. So if somebody has no peritoneal function, and that's usually the case if they've had PD before, and they've had to move to hemodialysis because they had UF failure from their PD, and then they go in and have a transplant, and they want to come back to dialysis, and they often say, could I try PD again? And I have a very high threshold of putting those people back onto dialysis. I have done it once or twice because sometimes they have some left graft function that's residual, and they've just about managed. And intra-abdominal adhesions that are going to limit the diazolate flow. Again, if you have a skilled surgeon, you can get around it. But if somebody's had radiotherapy for cancer, they've had a cystectomy, they've had a AP resections which has been reversed, it's likely that the PD won't work. And any patients with sort of uncorrectable mechanical defects. So anybody who's got a huge hernia, that's just not going to be operable because they've got too much comorbidity. In those patients, I usually say no to PD, but there are some relative contraindications which over the years have been translated into firm contraindications. So if somebody has had an abdominal vascular prosthesis, it's absolutely fine to offer them PD so long as the prosthesis is more than 4 months old, including those with VP shunts. If anybody's had a previous peritoneal leak, you can still put them back onto PD. Body size limitations, those who have been intolerant to large volumes, you could give them longer periods of time, but on smaller volumes. And certainly things like inflammatory bowel disease, things like abdominal wall or skin infections, frequent episodes of diverticulitis, severe malnutrition, they're all relative contraindications. And I would argue that if they're not for PD and they have all these issues, should they be on for dialysis at all? So, if somebody isn't for PD because they've got all these medical issues, then I would argue perhaps dialysis is not appropriate in that group of patients, especially if they're elderly and they have lots of comorbidities. But that again depends on, patient attitudes. It also depends on clinician attitudes. I mean, we have a very well-developed conservative management program where, if you do have patients that are in this group of have these conditions, then we are able to offer them, conservative management. And there's very good evidence that actually dialysis in certain groups of patients improves longevity by a few months, and that few months is spent in hospital. So at what cost would be my argument. And these are the two reasons why I don't offer PD to patients. So lots of peritoneal function and major crisscrossing of the abdominal cavity, because that's sometimes just asking for trouble. But if a patient wants it, then I will consider it, but on a case-by-case basis. And, successful PD programs really need 3 things. One is an active and effective education program, so being able to give the information to patients in an unbiased fashion without letting our biases affect things. Having trained nephrologists and surgeons and radiologists to be able to do the tubes and look after the patients, but very importantly, trained PD staff on the wards and outpatients or your dialysis centers that can support these patients. So that's what success looks like. I mean, there isn't fancy technology that's involved. That's all you really need. And it's all very doable because it just takes motivation. Just a reminder that PD patients don't just come from incident patients. We have had over the years patients that have switched from hemodialysis. We have a number of patients that have run out of vascular access, and there's nowhere even to put a line back into these patients. And, we've had good success. We've kept patients alive for a couple of years when, with the other option would have been to withdraw that therapy. And usually it is because the patient is either young or the patient is not ready to give up just yet. And don't forget those post-transplantation patients, so any patient who's perhaps had a live donor kidney that is now failing, they can still be offered peritoneal dialysis. And it's very common to have a disconnect between your transplant clinic and your pre-dialysis clinic, and these patients are on hemodialysis before you know it. And actually, these patients usually have some graft function going. So they're quite a good group of patients to put onto peritoneal dialysis because they will have some residual kidney function. I think it's really important to choose the right mode of insertion, and we've had to hone our procedural pathway over many, many years. And if somebody's body mass index is less than 35, they don't have any scars, then we offer them usually the peritoneal dialysis catheter insertion as a day case procedure. We're very lucky here now. We have 4 colleagues, including myself, who do these catheters. I am quite old-fashioned and I don't use an ultrasound scan, but my younger colleagues are very keen on using imaging and do that. And most patients are okay with 20 milligrams of lignocaine and a bit of tramadol and or pethidine or paracetamol to start off with. We also have access to interventional radiology. And the advantage of that is that we can offer sedation. We don't offer sedation for the medical catheters because we don't sort of encourage that, because when you're scrubbed, and I don't normally have an assistant that can gauge the amount of sedation patients need. So if a patient is very anxious, or we know that they will be better with sedation, young men usually, unfortunately, we then offer them radiological insertion, and that is also a day case procedure, but we do suggest that they're by mouth because of the sedation, and we use fluoroscopy guidance to do that. It's exactly the same as the way you would put in a blind percutaneous catheter, except that you can guide your wire with a bit of dye to make sure that you're going down into the right bit of the abdomen. We have 2 surgical pathways. One is an open pathway where patients who don't have any major comorbidities and are okay for a general anesthetic, we would offer the open surgical pathway to them. But patients who've had previous abdominal surgery, or if they require a hernia repair at the same time, or if they require sort of a look-see for something else, and we know that they have had adhesions before, then we always would refer them for a laparoscopic insertion. Now, the surgeon that we have can sometimes do laparoscopic insertions under epidural. So we're quite lucky that we have a variety of ways we can offer PD catheter insertion to patients, which really opens up a whole population of patients that we can offer PD to. But this hasn't happened overnight. When I started, we only offered it as medical and open surgical. That was all we did. And over the last 1.5 decades, we have honed the pathway a lot more. And what I would say is that you start with what you have, and then you build it from there. And is there a difference between how patients do, depending on how the catheter is inserted? Not really. There's no difference whether it goes in surgically, medically, or radiologically. So, one form of insertion is not more superior than another. And this is our own local data here. And it's been published before as well, but our data is quite granular, which really looked at, catheter insertion failure. And really, realistically speaking, it doesn't matter how you put the catheter in. So long as you can get the catheter in, it's likely to work. And if it works beyond 90 days, then good. And I just would like to encourage you to break the bias that hemodialysis should be the default modality of choice. I think with hemodialysis, there's always room at the inn. I use this slide quite a lot for teaching, and it's very tongue-in-cheek, so I apologize if I offend anyone. But I always say that the hemodialysis nurses always say, "I can't believe you got another patient for me." But we always seem to make spaces. Have you ever seen a dialysis unit with an empty chair? I haven't. We will always have patients for hemodialysis, but peritoneal dialysis takes work. Move away from this one-size-fits-all approach, and hemodialysis isn't for everyone, just like PD isn't for everyone. But at the same time, unless we start thinking, why not PD, we're not going to use it. Patient and clinician education is key. Most of us as clinicians who graduate from a nephrology training program will have only experience of peritonitis unless we've been in a specialist PD center. I wasn't a PD doctor. I didn't really have much interest in PD, and PD came to me by default because nobody else in my unit wanted to look after the service. So I wanted to give up one part of the service. So I said I would take it on if I could give up a particular aspect of my job plan. And I think it's really, really important to have belief in the treatment, because unless you exude belief in that treatment, your patients, and more importantly, the people you work with, ain't going to buy it. So, I think it's really important that you develop PD champions within the service. So I'm just going to end with the last two slides. I think it's really important to begin with the end in mind. So if you've got a patient that's always going to be on dialysis, transplantation is not going to be possible. Give them PD for the first couple of years. It will hang on to their residual kidney function a bit longer. Overall, there was a seminal study from Simon Davis, who's from Stoke-on-Trent in the West Midlands, that showed actually that you accrue survival advantage if you start on PD. Don't discount the possibility of PD because you feel that this patient's not suitable, because I think we sometimes do infantize our patients. I certainly am to blame for that as well, but I think we just need to change our mindset. PD is the best form of incremental dialysis. Why do you want to invest in incremental hemodialysis when PD has incremental dialysis built into it? It's not 24/7. You can do 5 days a week. You can do 3 days a week. You can do 6 days a week. You can do 6 hours a day. You can do 4 hours a day. You can do 4 exchanges a day. You can do 2 exchanges a day. PD and incremental dialysis are synonymous. The most important thing for our patients that dictates how long they will live is residual renal function, and you preserve that much better with PD than anything else. Education is really key, not just of patients, but of staff. And I'd urge you, and I'm a bit evangelical about this, and I apologize if I'm coming a bit over the top, but I think many barriers into PD lie in the thoughts of clinicians, not patients. So just please, I would encourage you to approach each patient with a very open mind. I want to argue that PD is hard work. Building a program takes time. I was saying to somebody the other day, PD programs are like rose bushes. You have to prune them. Hemodialysis units are not quite like rose bushes. I don't like to use the word weeds, but they're self-propagating. And this is the PD program when I took over in 2014. Not sure if you can see my pointer. We had about 8% of patients on PD. This is, I've not had the chance to update this, and this shows that we grew from 2014 to 2020 to about 18% of patients on PD. At the most recent count, we have 23% of our population on PD. So it is possible. We weren't a very PD-centric unit. I've had to convince a lot of people, but if I can convince Davy to apply for the Sister Centre grant, then I hope very much that we'll have the same effect in a joint way on your dialysis program in Mauritius for the advantage of your patients. So, just some pictures from around the world to say that you don't need any fancy gadgets to do PD. You don't even need, machines. These are improvised scenarios from around the world. It doesn't have to be automated. CAPD is as good as automated PD. Thank you for your time, and I really appreciate you giving me the opportunity to talk today. Happy to take any questions, and I'll just stop sharing if that's okay. It might be easier.
Thank you very much, Jyoti. I think if we had even just 10% of patients on PD in Mauritius would be fantastic. Well, be 150 patients. That would be a big program. Is Rizwan here to take questions? Can we see Rizwan?
I am here, yes.
Okay, right. Yeah. Okay, we can't see you on our screen, but
Have I stopped sharing, or am I still sharing?
Yeah.
I think you're still sharing, George.
Yeah.
Okay, I've got a question from the audience, and I invite other people to send the questions on the Renal Association group. Those who don't have access on the WhatsApp group, just come here and ask a question. So the first question is from Dr. Karan Singh. Dr. Baharani mentioned about PD for patient chronic graft rejection. What about infection while they are on immunosuppressants? How will you manage?
So I had this same discussion. I'm sorry, for some reason I can't stop sharing. I don't know why. It won't work for some reason. But it's an interesting question, and I think that's one of the myths that's been propagated. I think, if somebody is in the middle of immunosuppression because you think that they may recover kidney function and have started hemodialysis, then I usually just say, come back to me if the patient really wants PD and we will consider it. We've not seen an increased risk of infection, of peritonitis or otherwise. And I would argue that, going into a hemodialysis unit 3 times a week with a catheter sticking out, because that's what most of these patients will have, is probably a higher risk for infection. And we've also had patients who've been having chemotherapy for myeloma, that have been on PD, and we haven't seen an increased risk of peritonitis. Rizwan's probably got a point of view on this, so I'll ask what he thinks.
I agree, Jyoti. We have quite a few patients who've failed transplants that still have some residual function and are on tacrolimus, prednisolone, etc. And we put them on PD. I haven't seen an increased risk of infections.
Okay, yeah, I can see everybody now. While I wait for more questions from the audience, I've got a question. Talk about PD first, and I'm thinking particularly of Hong Kong, where the government policy is people who want to get government funding for their kidney treatment, they have to do PD, and they only move to hemodialysis if there is a contraindication. So I just would like to know what your personal opinion is. That too much of a draconian step? Should there be a degree of free choice?
Sorry, Davey, was that a question? I struggled to hear you a little bit.
Okay, yes, my question is, should we force patients to go on PD?
That's an interesting comment, isn't it? I think if your incidence starts going up. So when I was training in the early 90s, late 80s in Scotland, that was what we did, because we didn't have enough hemodialysis spaces, and everybody had to go on to PD in Glasgow. I didn't train in Glasgow, but in Glasgow and in Manchester, everybody had to go on to PD and when they failed, they went on to hemodialysis because they just weren't the slots. I think it's a bit bureaucratic to do that. And if a patient doesn't really want a treatment, they're not going to get on with the treatment. So I don't believe in that, but I do think that, in those countries, that was the only way they could get people onto dialysis. And I would argue that actually, in certain countries, this does have a place, but I suspect in a place with an evolved hemodialysis program like the States and in Mauritius, that won't go down well. And it also means that you will have patients perhaps that are not suitable for PD going on to PD, which will color the attitude of people who are already anti-PD. Does that make sense?
Yeah. Any comment?
So I feel that we should have a PD preferred policy where we encourage patients to go into PD because we know it's better for them. I think at the moment, unfortunately, we have a hemodialysis preferred policy almost everywhere in the world. I mean, by default, if somebody was to land at your unit this evening, Davey, with end-stage kidney disease and 8-centimeter kidneys, low calcium, I bet you anything he's going to get a hemodialysis catheter without being asked about PD. So my argument would be, why not put a PD catheter without asking? Because you can take it out if it recovers just as well as you can take a tunneled hemodialysis catheter. And Simon Davis has shown this to work. And we know that if you put patients on PD first, they are more likely to stay on PD than if you put them on a hemodialysis program and get them to switch. The barrier, I think, really is more, just as Jyoti said, I agree entirely with that. The barrier is within the clinician's mind. We tend to offer hemodialysis first. What I'm in disagreement with is that as a government policy, that you patients should not have the option. I think we should give patients options. I think we should, they should be able to make a decision about what they want. But, that is dependent on us giving them the right information, provided we are unbiased. And if we are unbiased, then we would say PD is a better option to start with. Which is, I think we are not. That's the problem.
Okay. Anybody from the audience, any question? Please do ask. Yeah, no, yeah. Okay, there's a microphone.
Good evening. My question is about the climate. Mauritius has a tropical climate and tends to get very hot in summer. So, is there anything like I think increased rate of peritonitis? So, since patients are being the purpose for peritoneal dialysis is so that patients can be independent. So how can we combat that?
So I'll answer that. I'm really sorry, I didn't see who asked the question or your name, but thank you for the question. I'd probably say that, Thailand is pretty hot and Hong Kong too. In the summer, we recommend that patients don't have an open window when they're doing the exchange, and don't use a fan. But if they're on treatment, so it's just while they're connecting themselves. After that, that's fine. I mean, I think again, Brazil is a very hot country. Mexico is a hot country. There's no sort of evidence that the heat increases susceptibility to infection. And I would probably also say that patients have more of a freer fluid restriction. So most of my PD patients aren't on a fluid restriction unless they have heart failure. And in a hot country, that's quite advantageous. I think that was the question you asked. You asked me about infection, didn't you? So I was struggling to hear.
Yeah, that was the question. I think I'd like to follow up on that and possibly draw Rizwan in. In Russia, so we have this perception that there's a lot of peritonitis, and also maybe think that patients cannot be trained. Is there any evidence that people with low education status have more difficulty in the PP technique? I'm kind of answering my own question because I've seen that you flash very quickly a paper from Colombia where people were doing PD.
So, David, there is evidence that patients from a lower socioeconomic status use less PD. But, this is probably a self-fulfilling prophecy, because if they're less educated from a lower socioeconomic status, we assume that these are clinician biases that they can't learn. Really, I don't think personally that you cannot teach a patient to do peritoneal dialysis unless they have some learning difficulty. But just because they're from a lower socioeconomic status or uneducated in terms of secular education does not mean that they don't have the intelligence to be able to use or learn how to do PD. At the end of the day, it is quite easy. The machine itself is available in many languages if you're going to use APD, for instance. But CAPD it's a simple task. It isn't very difficult at all. I mean, children learn it. So why should adults who, just because they've not been to school, not be able to learn it? I would argue that they can learn it just as well as the college professor.
I'm sorry, David, this is one of my pet peeves when somebody tells me that I don't think they'll be able to do it. And I say, do they drive? Do they have a bank account? Do they work? Well, they can do PD then. Because I think we kind of, we kind of make decisions for patients. These people are able to have children. They're able to have a bank account. They're living, and yet who are we to say, and by all means, you can teach people anything. And I've found that patients that we actually think are going to pick PD up like that really struggle sometimes, and people that people go, oh gosh, how are they going to cope? They've learned it in 2 days. I think Rizwan will have similar experiences. Yeah,
I mean, we teach our PD patients 3 days, sometimes 2. So if somebody needs 4 days, what's the problem? They can still be taught to do it.
Okay, there's a question for audience, somebody called Dani. So addressed to Dr. Baharani, but I think it should be addressed to Dr. Hema as well. How often do you use PD over HD in AKI? What is your center's experience?
Rizwan, I'll let you take that one.
So unfortunately, we use hemodialysis more often than peritoneal dialysis. And this is where the PD champion thing comes in. So if I happen to be on the ward, then I can tell you that I often do offer PD. The problem with PD is that it requires the patient a bit of training. Hemodialysis is easy, isn't it? In 15 minutes, you put a catheter in, and the patient's on a machine. So it certainly can be used. I do use it. I don't use it as much as I'd like to, but that's probably because of physician and nursing bias against hemodialysis, peritoneal dialysis, which exists in the UK as much as anywhere else, to be honest with you. Jyoti?
What about
It's the same. I think, if you've got somebody, and I think there's no harm in dialyzing somebody for the first few sessions with HEMO. It's if you think they're not going to recover, then I think it's important that you tell them about the modalities before they get discharged or early follow-up, because it's really hard once somebody's established onto hemodialysis to sort of suggest, oh, you move to a different treatment. Patients go through a lot psychologically, and I think the first modality, they save that life. They save that life tends to be the modality they stick to.
While we're waiting for more question, I've just had a quick glance at the survey we've been administering since lunchtime. We've got 62 responses, and so they are mainly before we started this webinar, and it's quite encouraging because I see that about 60% of people think that PD should be the first choice of dialysis modality for my patients. And in terms of cost effectiveness and being green for environment and quality of life, traveling actually is a small majority for PD. And even for if I had kidney failure, I would want to have PD. I'm quite surprised that more people want to have it than not. But where people are more negative, and I think that's from local experience, PD is easy to start in Mauritius, and only 30% felt that it would be easy. Any questions?
Davey, can I comment on that last statement you made, if that's okay?
Yeah.
When you say only 30% of patients of the respondents think it's easy to start, perhaps you have about 30 people in that room there. Perhaps you can. There needs to be a joint agreement that we want a willingness to increase PD, and then you can possibly try and overcome some of these barriers. Now, I know you won't be able to overcome all the barriers. There's government policy, and there are things that are out of your hands, but there are definitely going to be some things that you can do. So if you collectively say, let us make a list of the problems, the barriers, what are the list of solutions we can, you will overcome that. And if you can get one extra PD patient every 2 months, that will be 6 patients that you will have in a year, and 30 patients over the next 5 years that you will have put on PD instead of hemodialysis. So it is a significant proportion of your PD program just now, if you can manage to do that. It's just simply a matter of saying, do we all want to do it? So let's see how we can solve it.
Yes, I think we need to involve the various stakeholders, and I think one important step in the next few weeks is to get the Ministry of Health on board. I think people here are hungry, and I'm sorry that you won't be able to really share the dinner. It's no good having a virtual dinner. But before we
And
finish, I
hold you
want,
to that, Davy. We've still got to go home and cook dinner, so.
yeah, I want to do a very special thank you to Ducré Lenoir, local representative for Baxter, who has helped us with the technical side today. And I think it went very well. Just have a brief moment just before starting, where we heard some screeching noises, but after that, it all went very well. So it goes well for this program. So many thanks to Prof. Arobindale, to Dr. Hema, to Dr. Bahani, and hope to see you soon virtually and physically. Bye-bye.
Thank you, Davy.
Thank you, everyone. Good night, and look forward to working with you all.